Reduction Task Force. You're at the meeting of the Behavioral Health Subcommittee. Today is January 17th, 2023. We are meeting in hybrid. Most of us are here on Zoom, and welcome. Glad everybody could make it this morning. We always kick off this meeting with the land acknowledgement statement. And I want y'all to know this kind of comes from the heart. So I think we read it to make sure I don't have any missteps, but I want you to know that this is important stuff. Before we begin, we acknowledge that we're gathered on the traditional and unceded territory of our Lummi, Nooksack, Samish, and Semiahmoo neighbors who have cared for and tended this land as long as we know. Truth and acknowledgement are critical to building mutual respect and connection across all barriers of heritage and difference. We begin this effort to acknowledge what has been buried by honoring the truth. We pay respect to their elders, past and present. Please take a moment to consider the many legacies of violence, displacement, migration, and settlement that bring us here together today. And please join us in uncovering such truths at any and all public events. Jill, would you mind putting up the agendas for us real quick so we can review that together as a group? Suppose I didn't say who I am. My name is Mike Parker, and along with Dan Hamill, council member from City of Bellingham, we are both co-chairs of the Behavioral Health Subcommittee.
Yeah, thanks. Good morning, Mike and group and public. I'm on my phone right now, so it's really hard to navigate the and coordinate this. So thanks for stepping up, Mike.
That's why we got multiples of us, Dan. It's no problem. I'm sure I'll be in that situation as well.
Yeah. So
it's nice to see some faces I haven't seen for a while. Mike Smith, it is good to see you again. Doug Chadwick, it is really good to see you again. Welcome. Happy New Year. I know folks have been away for some time, but we're welcome to have you back. So I'm going to go up and since our meeting is already called to order, and I'm going to apologize in advance because I may mispronounce this particular drug. So, in multiple spaces in the past couple of weeks, we've been hearing a lot about the latest upgrade over fentanyl, to be sarcastic, but Xylazine, I'm not sure if I'm saying that correctly, Xylazine, fentanyl. And so what I'm hearing from some of our medical partners is kind of creeping its way from the East Coast. And we were working with some folks in Snohomish County who said that their law enforcement down there in Snohomish County is seeing a severe rise. A couple of pieces, I'll just frame this up a little bit, and then I want to invite discussion. I don't know if we have a presenter today on this particular one, although I see Mike Smith, and I'm guessing he could lead us a little bit more intelligently. I'll share a piece about why we wanted to put this on our particular agenda today. As you know, we not infrequently choose to dive into a particular scourge because it is what people are dealing with. It's what our law enforcement is dealing with, and we know we're eventually going to see it in our court systems and in our jails. But this particular issue, Xylazine, and how I was exposed to it, is somebody was trying to use a fentanyl strip and trying to make sure that something they were about to use didn't contain any fentanyl. Well, guess what? The Xylazine didn't show up on his fentanyl strip. And I don't know if that's true in all brands or not. So, it seems like when we get a defense or we get a harm reduction measure, we've got something new that comes and attacks people, right, who are addicted and may not know better and may not even be able to see it. My understanding is this stuff is incredibly is deadly and very risky. So I think in order for us to be able to see what people are dealing with, what our providers are going to be dealing with, we wanted to bring this to the attention today and bring this to the subcommittee. With that, I'm going to invite Mike Smith and see, Mike, what can you tell us about this? What can you share from a treatment provider perspective, if you don't mind me just calling on you?
No, that's fine. As far as a treatment provider perspective, we haven't really seen it because our labs, our UAs are only 13 or 14 panels. So it doesn't even test for Xylazine. As far as, we don't even really see it in the wounds. Xylazine gives a lot of wounds that are a lot deeper than the abscesses that you see normally with opiates. So it's a whole wound issue, wound care issue as well. It really looks like it's on the East Coast and it's working its way slowly. I saw quite a bit of research that it's really concentrated in New York and Philadelphia, with Philadelphia seeming like it's the hub of it. I was looking at to National Institute on Drug Abuse, and they're saying like it's 50 times worse than fentanyl. As far as the animal tranquilizer, this is what they're calling trank. I also, know personally from areas I grew up in that term trank is new. Xylazine, I hadn't really heard of that before, but animal tranquilizer has been used in substances since the 50s. Like, we're talking about PCP, they were using it as a cut, as well as like formaldehyde. We know that this population, right, the nicer the nice, the higher the price. This is the high that they want, though, right? I mean, to us, it's a medical problem, but for this community, this population, go team. That's what we're looking for. Where has this stuff been, right? I mean, and that's the sad part of it as being providers. Outside of that, I don't really have much else to go on. It's just that we really don't see it here yet, and maybe it's just not in Bellingham yet, but I'm sure it is in Seattle. I didn't get a chance to talk to some of my other folks down in Pierce County and in Seattle about it, but I hadn't heard anything in the grapevine. Normally I'll hear something about it like that, but I'm sure it's there. What Canada is doing to combat it is, I have some notes here, safer opioid supply. And what the prescribers are doing is they're giving out safer opioids, like they're actually prescribing heroin, they're actually prescribing fentanyl. So the population that we're dealing with actually has safe drugs. I mean, so they're really doing it from a harm reduction model. A lady named Kimberly Sue at the Addiction Medical physician from Yale and former medical director at the National Harm Reduction Coalition. They're standing behind it. They're saying that America or the US is quite behind in their drug policies. They're saying that they're seeing a difference, a drop in the poisoned street drug scene by doing the safer opioid supply. So that's kind of all I came up with, all I really can see out there. There's a lot of research, a lot of articles, a lot of things about the xylazine. But as far as the animal tranquilizer, the substance abuse population they've been having this for decades. So this isn't really something new. It just may sound new because they're using a different animal tranquilizer, but they were using elephant tranquilizer and stuff like that in PCP from the 50s. And that's actually in the National Drug Intelligence Center. They have a publication about that, talking about how long ago that this has been around. So this is definitely not something new. It just has a new name to it, and it's probably just a bit stronger.
Mike, you said its street name it goes under is Trank?
Yeah, Trank.
Mm-hmm.
Yeah, and it's just short for tranquilizer, right? I mean, they always got nicknames. I mean, fentanyl, there's a rapper called Fetty Wap. Fentanyl in Tacoma, Seattle, and LA, they're calling it Fetty. Blues. I mean, everything has nicknames, has its nickname. So, Trank is just a short word for tranquilizer.
Hey,
Yeah.
Mike,
Go ahead, Dan.
got a question for Mike Smith. I'm trying to understand the why on the trank, and we had talked before about benzodiazepine combined with fentanyl, and benzo is like a muscle relaxant, and so you kind of get into like a bit of a stupor.
Right.
And the trank is similar. It kind of knocks you out. I'm trying to understand the why on the user part and the why on the supplier part. Like why would the user crave this type of experience, and why would the supplier then provide that? Do you have any ideas on that?
Sure. I mean, well, there's uppers and downers, right? Some people like the speed. Some people like the meth, some people like the down, some people a lot of people like alcohol, the central nervous system, right? It relaxes you. It puts you in a down state. So there's actually a book out there called Uppers and Downers. A lot of people just like to feel that euphoric feeling of the nod, right? I mean, it feels good. It does, especially the people who are in pain, mentally, emotionally, and physically. A lot of these folks have been out there using to where they are in pain. So it's addressing multiple issues in multiple different ways. As far as why the dealers would use it, is because you want the best dope. When you're in the streets and you're selling dope, you want the best dope. You want all the sales, right? So it's a competition. If I'm selling drugs and Joe Blow over here has just, you know, the regular or the reg, I want the nicer the nice, the higher the price, right? I'm gonna be able to raise my prices, sell less for more, and then the clients are gonna come because I have the best dope in the town. And so that's what it's about. And as far as the manufacturers are gonna use that instead of a cut, so they can actually sell you less with more cut, and the cut just happens to be drugs too, but they can get it cheaper than making the heroin, right, than the opiates, right? And so they're going to be able to use that instead of adding more opiates to opiates. They're using the animal tranquilizer instead. So I can just use less fentanyl that I normally, let's say I got a brick like this of fentanyl, I can now cut that in half and add animal tranquilizer. That's cheaper than selling you the whole brick of the fentanyl. And so they're just using it as a cut, kind of like blow up is what they do with baking soda and B12 with crack back in the 80s. You add the baking soda and you add the B12 to it and you blow it up to a bigger piece, a chunk of hard cocaine. Well, the cocaine amount in it is really this much. The rest is blow up, but it weighs the same or it weighs more. So you're being able to sell the weight at a higher price and actually less product. So it makes sense on that side from a sales perspective, as well as the corner of market. And so that's why the manufacturers are doing it like that.
Thanks, Mike.
Yeah.
Mike, and this doesn't just have to be you answering this, but since you're kind of leading us in this discussion, and I'd like to hear too from law enforcement up here, one of the things that we heard from Snohomish, from medical professionals and some law enforcement, and why they were particularly troubled to see this, is that it, you know, as I mentioned in my framing comments, it wasn't showing up on fentanyl test strips, right? So this particular medical professional had just been trying to kind of, from a harm reduction lens, push out fentanyl test strips so that people could be a little bit safer, and it eludes that. Mike, you brought up that it's either not showing up on your panel, right? So when you're doing intakes, right, you're not seeing that people are using that. I understand it's very difficult to detect. And then third, and this is something I don't know, but something that was posed to me as a potential risk, given the intensity of the high, essentially, what would it do in terms of like overdose risk and or ability to reverse under naloxone? And those are two questions that I have, and I wonder if anybody might weigh in on some of that. Under Sheriff Chadwick, please.
Sure, you're right there. As far, so obviously the whole intent here is to increase the high. I understand it's a longer high, and I don't know that we've seen it here in Whatcom County, the Xylazine. I can certainly reach out to the medical examiner who does the tox screens on overdose deaths and those kind of things. And if she's not looking for it, maybe see if she can actually test for that. But that's the risk, is that because they're both a depressant, and as Michael said, it's a central nervous system depressant. So at some point, if your body slows down to the point that you stop breathing, hence the overdose, if you hit somebody with naloxone, Narcan, it only is going to react to the opioid in their system. Naloxone only works on opioids, so it's not going to address the overdose from the Xylazine. So potentially somebody could still stay in that overdose state where they've stopped breathing because of the combination of the two.
Mike Kelly, I see you also on the call here. You know, Mike and I are working with a group trying to kind of spread the use, availability, training, capacity of the community to do overdose reversals, right? Through the use of Narcan, whether that be the nasal spray version or injectable. Mike, what I'm hearing about this is exactly what Under Sheriff Chadwick says, that it would work on any opioids present maybe in the mix. And as Mike is telling us, we might get kind of a complex blend that the user might actually be using. What are you aware of any responses to that so far? Is there something that does help in these situations, and does that put at risk widespread naloxone reversal medication as kind of a panacea?
Well, yeah, thanks, Mike. And Mike Kelly here. So yeah, there's really nothing else that can reverse those polydrug overdoses like that. In fact, that's a real problem when you wake up somebody that's got a mix of methamphetamine and fentanyl at the same time. You wake them up and keep the opioid off, but then they are super hyper in that disorientation. And actually, it just becomes more problematic as these analogs change, you know, time after time after time. One of the things I've been concerned about in the community is because of this issue is that people really aren't concerned about doing CPR because it's that magic, you know, drug up the nose that's going to fix everything. And from an EMS standpoint, and we really want to reinforce the CPR message. Just many times that may just not be the case. As far as the Xylazine goes, we haven't. So this group would be glad to know, and especially Councilmember Hamel, the ME Dr. Hunt actually participates in the I-5 reporting drug overdose deaths. In fact, they put out a monthly newsletter. I'll be glad to send it to the group. I looked at the September, October, November, December one. There was nothing listed in there with a Xylazine reference to it. There is an other drug reference that's like super small. However, I did notice that 4% of the deaths were related to benzodiazepines, and Xylazine is probably similar to a benzodiazepine in a much larger dose. So you may see it come up as a benzodiazepine analog as well. But yeah, no, I agree. You know, as we kind of, this whole thing changes, the messaging changes on how we're going to take care of people in the street, especially with the proliferation of Narcan, and while that may be great. And it also kind of throws up the question with the fentanyl strips. And so we have a project going from a grant from SAMHSA for some education. They were really emphasizing the use of fentanyl strips. However, as I talked to many people around in the aspect of harm reduction, there's maybe some hesitance to push that out for exactly the reason you said, which is, you know, it would make you feel unsafe or make you feel safe to take the drug that you're taking when you're really not. And so, you know, I think we need to talk about that just a little bit if that's going to be an emphasis, because as these analogs change, I'm not sure it's going to be as much of the safety thing as we have or not. I just don't know, but yeah, definitely need to change, I think, some of our education and outreach on this.
Courtney, I see your hand up. Please go ahead.
I just wanted to chime in on how Mike ended there with the conversation about education, training, how things need to change. I want us to always remember in this conversation about substance use that we have to remember trauma and mental health. And until our community can provide the providers who can provide both, we are not treating the root of the issue.
Courtney, if I could just clarify, are you getting at kind of co-occurring disorder treatment, kind of addressing both of those at the exact same time? Okay, not dissimilar to what Mike does in a inpatient setting.
Right.
Gotcha.
Yeah. And so what I'm saying is that we don't have enough of that. We don't have enough mics. We don't have enough people that can do both. And so these conversations that we're having with this zoomed out perspective, like we are on these task forces, I'm concerned that we are not, if we're going to talk about substance use and why people use and why they continue to get sicker, why they use more things, why they end up at the jail represented by our office, it's because they do not have appropriate care in the community. They do not have the means to survive. They're using to get by every day, and they don't have appropriate care. And so again, I'm just trying to bring back that holistic lens that we have to have.
Really appreciate your perspective. Chief Tank.
Sure. So the University of Washington Addiction, Drug, and Alcohol Institute, they send out a newsletter. And what they reported in their last newsletter under the topic, new and emerging drugs and the crime lab. So in the third quarter of 2022, they did specifically talk about this drug. And in the state of Washington, for that third quarter, it was 10 cases and 10 cases around the entire state. 2 of those cases, which were in Whatcom County. So additionally, what I read in terms of the post-mortem toxicology with regard to overdoses is that oftentimes those medical examiners were not testing specifically for this drug. So therefore, some of the data and the information, not only that the crime labs have, but the coroner's office or the medical examiner's offices might not be accurate. But with that, there is a professor in charge of the University of Washington Addictions, Drug and Alcohol Institute by the name of Dr. Caleb Banter Green that I know. So I'm wondering, I can connect him or one of his associates to this committee, to the subcommittee, and perhaps maybe bring them in to do a brief report on this emerging drug. Thanks.
Co-Chair Hamel.
Chief Tank, thanks for bringing that up, and I would support that. I want to speak to Courtney's remarks. You know, we keep treating outcomes here, and instead of inputs. And you know, I'm on the SAC, the Stakeholder Advisory Committee for the Justice Committee that's working on the jail recommendation and services. And you know, I really want to make sure that having services within the jail facility are at the top of the list. My concern is that jails throughout the country end up being the kind of de facto mental health treatment centers for counties across the country, because there really is no comprehensive provision of services in the community. I'm not quite sure where that lands within this committee, because we're here to make recommendations to the county council in regards to kind of basically like public safety issues, and I'm not quite sure where it lands, but it seems to me that going upstream is the best way to address issues versus treating the outcomes of broken individuals that have like severe trauma and are committing crimes within the community. So I say all that because I want to let the committee know that this week I'll be going to the juvenile justice facility for the first time in 9 years that I've served on our city council and on this county committee to understand better what that looks like for kids, because everyone starts as a child, and that trauma can be introduced when you're a kid. And so I want to better understand that, but I do want to put a pin in this conversation when it comes to the trauma that people face and why they are using these substances in such a way where, you know, regular, quote unquote, regular people would be like, why would you use an animal tranquilizer in conjunction with a potentially deadly fentanyl pill because they're traumatized? And that's not everybody, but that's a lot of people. And so I just wanted to bring that forward.
Thank you for that. And welcome back, Heather Flaherty. It's nice to see you. I see your hand up. Please, yes, go ahead.
Thanks for the welcome back. And I think this was the drug that was just published in the New York Times, right? The really bad vet drug that like makes people have to be amputated because of the wounds it causes, right? Okay. Courtney, I really appreciate your comments as well. And I've been thinking about what is our role as this committee and task force in building those things that we know we need, and what's our comprehensive plan for public safety, especially as that stakeholder advisory committee process unfolds this year, and we're talking more and more about we need a new jail. And there's a couple lines of logic that I just want to say out loud. One is the facility is terrible and no one's getting better there, and it's not even it's a humanitarian issue. So we need something to change. But then there's that argument of we see this rising crime and it's because of the jail. But who is in that jail and why? And we've heard stats that are alarming. About 98% of the people in that jail right now are there because they can't get the competency hearings or restoration services they need. The trials aren't happening. I imagine there's a high incidence of mental health and co-occurring behavioral health and addiction. And so it makes me start to go down the logic train of, well, I think what we need is a treatment facility. And so I just want to say that because I think our committee has a really big role, and we've done that. Like, this committee has been amazing at, we see a need and we've advocated to fill it. And some of us just went to that renaming facility for the crisis stabilization. And so what's next and how can we help fill in those gaps? This drug is really scary and alarming, and more I'm hearing about the drugs that there just doesn't seem to be any treatment or services for. And so it's like, well, then what do we do as a community for these people? And I hope to help build those solutions with you. And I think some of this will hopefully lead into that next agenda item really well with the legislative priorities. So thanks for letting me take a little extra time just to share what's been on my mind.
We really appreciate that. Perry, please.
Yeah, just to follow on what Heather was just saying, there is an imminent report that is coming out. I don't know if you've heard about this. The North Sound Behavioral Health Administrative Services Organization has brought on an outfit called Percival. They are a health statistics and information company, and they have just completed a needs assessment relative predominantly to inpatient and outpatient services for SUD, co-occurring, and mental health. And it's not, I wanted to look today, it's actually, there's a draft that is on the BHASO website. But I know that they were actually completing that, where they were finalizing some final statistics and so forth. And I think that that will inform us relative to what should we be looking at in the region, not just specifically for the county, but what are the needs and what are we seeing related to what we have available at this point in time in regards to those kinds of services, and also taking into account a couple of things. Obviously, our population increase and also the age of the population is something that they included. So I just got an initial look at it. I can't really speak to it with great depth, but I think that this is going to be a really important document for us to be considering in a number of these different groups. So I wanted to bring that to everyone's attention.
Not seeing any other hands at this particular time. I do kind of want to bring us to a spot of maybe a little bit of closure so we can move on to the next agenda item, but B, kind of thinking about where do we take observations that we bring her. This is a little bit to Heather Flaherty's point, is so we don't do this just so that we have an understanding and then go home just a little bit more understanding. We want to take it somewhere and do something with it. And this is a little bit of teeing up for our next phase. But, you know, when we've run into issues before with our behavioral health workforce, leaving for private practice and not finding enough pay, you know, that's one of the issues. We know that we don't have the treatment options out there. We don't have enough Mike Smiths out there and the outfit that he runs. So that has been one thing that the committee and some members of the committee and task force have been looking at. Well, how do we advance this knowledge that we might come across here? How do we work together in a positive way to address things? And this particular drug, it seems like there's more that we need to know. And I think some things that just came out, at least to me, that strike me, and I'm sure we'll get them kind of in our notes too, but the fact that we can't track it is going to be really difficult. So when I heard Under Sheriff Chadwick say, hey, we're not kind of testing for that currently, might look into doing that, I think it's going to be really crucial. And then what we heard from Mike about the report, that it's not tested widely around the state, means we've really got something hidden. And I think, you know, so to whatever extent Under Sheriff Chadwick can pursue that, I think that is a really good angle, because if we don't know about it, we're not going to be able to do anything about it. Second, I think there usually are multiple implications whenever there's a new drug. And I always think about it from multiple standpoints. Yes, we have the traumatized people that are going to be using them, but also our treatment providers need to be equipped and need to have knowledge. Our law enforcement does, emergency responders. So the whole system really is going to need to adjust. And what is the role of the committee in doing that? And, you know, I would like to take Chief Tank up on the offer of maybe connecting the doctor that he mentioned. And Chief Tank, my apologies, I did not write down the name. I know it was a 2 or 3 names out of the University of Washington for a future meeting, which might give us a little bit of time, one, to delve in slightly deeper, two, to get a little bit more of a finer pine on what are the nuances of this that we could, by some advance notice, maybe it's not so prevalent here, that we might be able to be more responsive. And while we can't maybe eliminate it from the street, if we can be more aware and have all of our providers and community providers and first responders aware of something, hopefully we can stem off the worst possible effects. Heather Flaherty, I see your hand up.
I don't want to interrupt you, but it made me also think it would be wonderful to have those reports come to both from behavioral health ASO and the UW. And I've also been wondering about our local harm reduction programs and the needle exchange, and just wondering if it would be appropriate to ask for an update from them at this committee, just to hear how that's going and what the best practices are. I think that it would be really nice to be equipped with responding to community complaints about those kinds of programs. And that's part of the spectrum too, I think. So.
Excellent point, duly noted. Under Sheriff Chadwick.
I just want to clarify, I will confirm with Dr. Hunt, our medical examiner, on if they are or not testing for xylazine. I'm not sure, but wasn't aware of any cases where that was brought up. I know they're seeing a lot more fentanyl overdose deaths, so I will confirm that and report back at the next subcommittee meeting.
Great, thank you for that. 2 other thoughts that I have before we kind of wrap up, and then I'll offer it out again if somebody else had a question. You know, when we think about in this term comes up a lot, but upstream, right? We want to catch people before they're falling in, and what kind of things do that. And I think about, obviously, you know, child and youth and family well-being, and assuring that people aren't getting traumatized in the first place. There's lots of points, right, along our PETA continuum, which is essentially our framework, right? We look, of course, the life course of somebody, where can we intervene? The other thing that happens, and I'm sure Mike probably sees this too, and I saw this, almost every person I saw deeply addicted, there was a lot of homelessness association or housing instability. So, you know, yes, these things are happening at youth, but the trauma and things persist as young adults and as adults. And if we don't have housing, people don't get better. And when people are come out of a forced abstinence period in one of our facilities, let's say it's a jail, they have a unique opportunity to do something different. And we are still not in this community doing a good enough job. When people exit and have served their time, we are not doing a good enough job getting those people housing and working with them to find out, you know, how do we work towards employment so that you're not have the only option in heading back to the life that you had. And we're also not targeting, in my mind, housing resources for those individuals. So I think, you know, I know there are so many different ways that we might address this. I just want to bring out that very basic tenet that nobody really gets better on the streets. We see so very few people get better or kick whatever addiction or resolve their trauma or heal. And I just want to kind of stick a plug in there as we think about interventions, as we think about community response to these problems. There's many stages in that life continuum, and every ounce and every penny we put into youth is extremely important. But we also need to address our young adults and our adults as they're also being affected. Anything else on this before? Oh, Perry, please go ahead.
Just really quick, the individual looks like Chief Tank may be on another call or something. The individual that Chief Tank was making reference to was Caleb Banta-Green. He is an affiliate assistant professor at University of Washington, and has been a longstanding researcher with the Addictions, Drug and Alcohol Institute. So you can literally, if you Google, you know, Caleb Banta-Green, the information will come up, as well as information relative to the Addiction, Drug and Alcohol Institute. They have some great research, some great reports that they send out, you know, that sort of thing. So just wanted to connect to that. And, you know, relative to what Under Sheriff Chadwick was talking about in terms of testing, I don't know this for a fact, but we sort of touched on it, and I hope that, folks are clear that test strips for fentanyl obviously, well, clearly are not going to show xylazine. Xylazine's a sedative. It's a non-opioid substance. So, and interestingly enough, at least it's been a little while, and so the technology may have increased to some extent. As Mike was talking about the 12 and 14 panel urinalysis tests that are done. The testing labs, at least as I work with them, they have available other panels that they can include on that. There's of course a cost connected to it, but it tends to be pretty specific to the substance. And so, for example, that could be added, but when, we were talking about this before, that there are a number of different substances that are out there and they tend to sort of ebb and flow and change. That it's a real challenge in terms of, adding that one and then whatever the next one is that, that will come up. And so not to necessarily put a damper on it, but to be thinking about it from that standpoint and saying, okay, the pharmacological nature of these substances is that it's a very specific test that needs to occur in order to identify that. The thought struck me, boy, doing some research, I certainly will, do some research on urinalysis testing that is typically used and what an expert in that arena might suggest relative to these. This isn't a new and emerging substance, but an emerging substance, I guess is what I'll say. So hopefully that makes sense just in regard to that. It's sort of like we get some information in particular with xylazine, and this was mentioned, Heather made reference to this, that some real concerns around the fact that the use of this substance not only increasing the risk of overdose, but the related abscesses, skin ulcers, and challenges that are occurring relative to the use, obviously, particularly when it's used intramuscular or intravenous. And so some real health concerns that are coming up that are very immediate in that regard. So.
Perry, I think that would be very useful to bring to a future discussion. And I think, Dan, I'll just kind of get a nod for agreement. We need to put this on another agenda and bring some more additional information and maybe a presenter. Mike Hilly.
Yeah, thanks. I just wanted to add on what Perry says. It's pretty.
Mike, I think it muted on you.
Sorry about that. Yeah, I just wanted to add on what Perry was saying, because it's super important to understand that when the medical examiner is looking, at an autopsy and they do a toxicology report, a lot of times you'll see these drugs pop up in their general classifications, right? So you screen and it shows an opioid, but you got to dive deeper into finding out what type of opioid it is. The xylazine is very similar to clonidine. And so it might pop up in a general classification, but then you would have to get down into it to find out what particular type of antiemetic it was or what type of sedative it was. And so as it becomes more popular, then you'll see the specific test go for it. I just emailed out to Jill for the group, the December ME report, which all the MEs up the I-5 corridor report into this. And that was for the December numbers. And you can see as that ME does that report, they're typically by general drug classifications, but there is some specificity on it. So for example, you'll see benzodiazepines, but there's a dozen different types of benzodiazepines out there. So you wouldn't readily identify, Valium over something else. And so I just think that's important to remember, as Perry was pointing out, that there's many general classifications, these drugs, and they pop up on a topic.
And Mike, I'm guessing you didn't mention this, but like Perry mentioned too, everything that we screen for and test for is either another process, another time, or may cost some money, right? And so I think that's part of the challenge these new drugs present, is the little bit of whack-a-mole, right? And how much do we spend time, money to get a handle of the new problem before the next one comes our way? Co-Chair Hamill, please.
Yeah, Mike Hilly, you referenced a drug that shows up similar to xylazine. I was just taking notes here. You said, what was that drug? Was it clonidine?
Yeah, I think the human version of a similar version of it is clonidine. I see that as as a prescription med every now and then with patients with certain conditions. And then, the xylazine itself is very similar just to a sedative for the animals to be used during surgery. So it's a sedative as well as a muscle relaxant when they're doing a surgery on an animal. And they're similar analogs for use in humans. They're just different doses, etc.
Thanks for clarifying.
And then just one brief thing that we didn't hit is we kind of agreed to put a pin in this, to revisit this and to add some information. From those of you who have a little bit more skill and facility with this particular animal, my knowledge about benzodiazepines, they're challenging on their own, but then you mix them with alcohol and they become incredibly deadly. What are the contraindications, or maybe pro indications, what Mike Smith was getting at? People are looking for a bigger high. How do I add something to this to get it even more? Is alcohol tending to be, like other benzodiazepines, particularly risky as a combination, or is anybody aware of how this thing might be combined in a way that makes it even worse? And if there's not, we can just add that to our research question list.
Certainly, Mike, Mr. Smith, jump in by all means. But one of the things that we do find, for example, you were talking about benzodiazepines, which is a specific drug class, has a long half-life. It remains in the body for an extended period of time, as opposed to, say, for example, alcohol, sedative hypnotic. It clears out of the system fairly quickly. What we tend to find is that, one benzodiazepine and one, alcohol dose, actually it multiplies. There's a synergistic effect with that substance, and the primary concern is central nervous system depression to the point of where breathing stops, and that sort of thing. But really tough, at least from my experience, really tough to estimate, okay, what will happen, if this is mixed with this? I mean, it's particularly dangerous, and it certainly multiplies it. But then you have obviously the individual person, their body, and the unknown, of course, and the factor of, well, somebody told me when they sold it to me that it was benzodiazepine, but I don't actually know, of course, what it is. And so the other thing that, is that I was really tracking when Michael was talking was that this is actually a pharmaceutical medication. That it's made out of a number of different chemicals. It is used in veterinary work and has been for years and years and years, which what then I find tends to become an occurrence is it becomes more available by virtue of the fact that it is synthetic. That is, it's created in a laboratory, and it's also used in, veterinary medicine, of where possibly there's less control of the substance than there is in other substances that would be typically used in medical situations for people. But I agree with you, Mike. The combination of substances has, is a real concern, and what to do with it, just in terms of being able to understand, know what's going on, et cetera. And sadly, I think that it's a great point from Mr. Hilly bringing information from the ME's report. But sadly, of course, we're looking at, what's occurring across the state in a post-death situation to be able to respond to it, as opposed to, something that's more, that we could more respond to effectively. The information is there, so we'll certainly use it, but it's a sad state that that's where we need to go to get that information.
Yeah, no, well said, Perry. That's an excellent point. And I believe it was Heather, but we want to include, and I'm saying this out loud too, so we catch it in the notes, but we want to catch harm reduction efforts. So one of the things with some of the professionals I was dealing with down south who are starting to see this, and Shoreline and Linwood, I think, were some of the communities that were starting to see this, is when folks like on calls like this become aware of this, we can spread that information out to people who have direct relationships with users. And whether that be needle exchange, maybe that's an ideal one, although, we're hearing that adherence of needle exchange are going down as the different types of drugs that people are availing themselves aren't always using clean needles, right? And a lot of people are ingesting those drugs in different ways. But there are other trusted individuals out in communities, harm reduction, street outreach, even our officers and our EMS, right, to some degree, become harm reduction messengers. So, you know, as to what we do with this information, I love Heather's question. I think that's part of what we can do too, is make sure that we're on the same page with those who might get information out to people who could save their life, or maybe make a different choice, right? With that, I'll go ahead, just in the interest of time. We do have another agenda item on here. You all heard me talk quite a bit. I'm going to turn this over to a couple of folks that were also on a subgroup. I'm just going to tee this up very briefly. So our next agenda item, as you can see on your agenda, is really to report back to the committee about a wish list. And some of you were with us. The Behavioral Health Subcommittee entertained Joe Valentine from Behavioral Health ASO. We also, in that same call, entertained Representative Alicia Rule, who was reelected to her post, and as our a representative in the 42nd. In that discussion, several things came out about our behavioral health system. And Representative Rule kind of pushed back on the committee a bit and charged us with, you know, what can we do at the legislative level that might give you some traction? So a group of us agreed to meet after that call, and many of them are here. I don't see Arlene. She was also part of it, but Courtney, Stephen, Brian Estes, and myself got together to kind of refine really what we've taken from the Behavioral Health Subcommittee in terms of our priorities. And whether we set it in an agenda, we've done it in a letter to the county council before. So we've iterated, right? What do we see? What's really important to deal with? We tried to encapsulate a small list that might represent a wish list. And quite a process ensued with many meetings and lots of learning happening. An eventual meeting, a very productive meeting with Representative Rule and Shoemake. So this is really kind of a report back to the committee, kind of full circle to some degree about those activities, what that list was. And I would say a thanks to everybody that was involved in that. And we're not done. So there may be room for you to be involved in that. So with that, I'd like to turn it over either to Stephen or Brian, who might just do kind of a recap of, you know, at least starting with what those bullet points were briefly, and what do we see as next steps, and then specifically to touch on a new ongoing work group looking at the competency evaluation, not even really restoration yet at this point, but competency evaluation, and how can we make some or recommend some situational improvement for conditions for inmates in our jail. So with that, I'll stop and I will invite, I see Brian off mute. Maybe it'll be Brian who could tee us up on our wish list.
Well, Stephen, I thought maybe you might be the best to present this, but let me just ask Michael and Stephen, did you see the changes that I put in a Google Doc over the weekend? I modified our text just a little bit based on our discussion last week.
I received that, Brian, but I haven't had a chance to read it. I'm sorry to say.
Okay. I just wondered, can somebody share the screen with that? I just made a couple changes to the legislative ask.
Brian, I don't have the document you're referring to, so I can promote you as co-host and allow you to screen share.
Oh, okay.
Does that work?
So Brian, this is substantially the same points that we shared. We'd be able to review, and then Stephen could talk to that to frame it. But additionally, then you've got some changes. Stephen, I don't see any challenge with that. That would be great. If you don't mind, Brian, you could do that, and then Stephen could do the once over.
Okay, let's see here. Just a minute.
As Brian is bringing up his screen, the other piece that I would just mention is, you know, obviously in this committee, we reach things that we can't fix. And as an advisory group, right, we have to advise people. We realize that sometimes our primary targets might be the Whatcom County Council. It might be, and that's our official charter, to some degree, Bellingham City Council. But we realize that some of the things we can't fix at our own level. And so this is the first, at least in my time being with the task force, that we've really taken some local issues that we need some state either authority, funding, or assistance in resolving. And I hope it's the first of others. With that, I'll stop. And Stephen, take it away.
So the the subgroup that developed this came up with a long list, but eventually pared that down to 4 items that we wanted to put at the front end of Representative Rule and Senator Shoemake's work during this session. We tried to frame them in ways that in terms that indicated they affected not just Whatcom County, but many counties around the state because they were systemic issues, hoping that that could draw more interest from a collective of elected officials. So the first one is an ongoing one having to do with the operational funding of the Crisis Stabilization Center, now the Ann Deacon Center for Hope. As you recall, we got the capital funding, built it, and then found that we had trouble securing an ongoing comprehensive operational funding scheme for that. Senator Shoemake, who was then a 42nd district representative, got a budget proviso for the 2019-2020 biennium, and then Representative Rule got one for the 21-22 biennium. But those are budget provisos that they just stick in. You have to keep going back and doing those. We wanted a mechanism that, and Brian's blue editing identifies that quite clearly. And this is something that Ann Deacon herself preached repeatedly. Right now, services for Medicaid recipients are funded on a fee-for-service basis, so that the service that any individual gets, that unit of service gets reimbursed. The behavioral health ASO provides funding also on a fee-for-service basis for non-Medicaid individuals. But as Ann kept saying from the beginning, what we really need is a firehouse model where it is fully funded, ready to spring into action 24/7, 365, whether somebody's there actually receiving service in that moment or not. We don't have that. Representative Shoemake's 2019 budget proviso called on the Healthcare Authority to work with the managed care organizations to develop an alternative funding model. To our knowledge, they certainly haven't succeeded. I don't even know if they've attempted to do that, but that's not in place. So we may need to fill another 2-year biennium hole with a budget proviso here, but we were looking for, as it says there, a secure, ongoing, adequate funding mechanism for operating costs. There is some county behavioral health tax money. And so it became clear after we talked about this, as it did on a couple of these points, that the funding patchwork for the Crisis Stabilization Center is much more complex than most of us lay people realize. Perry's been very helpful in helping us understand that. And you see a little better explication of this in Brian's editing. The second wish list item we came up with was, we have been talking about workforce issues, and Perry and Jackie Mitchell, when she was still at the health department, meet regularly with the behavioral health providers, the on the ground service providers, about recruiting, retaining workforce, and especially at this highest, most acute need end of the behavioral health service system. They're having real problems. And the Healthcare Authority periodically does reimbursement rate studies, and then those are not required, they're advisory. They pass that down to the ASOs. It gets passed on to the managed care organizations. Again, they're not required to utilize that information. They then negotiate contracts and reimbursement rates with those behavioral health agencies in the community. All of that is sort of a win-lose negotiation. And as we heard Joe Valentine report in the meeting Mike referred to, last year's 7% budget increase for behavioral health services filtered down into close to nothing for the direct service providers who we really need to recruit and retain. So our goal was to increase the reimbursement rate for those people and their direct supervisors so that we actually could incentivize and address, at least to some extent, the workforce problems we had. So we framed this as a way to do an end run around the healthcare authority, the managed care organizations, and the rather lame and unenforceable reimbursement rate setting process that is in place now. I think Representative Brule understands this process, but we haven't really been able to dig into this and talk about the feasibility of this approach. We're hoping to sit down with Joe Valentine and strategize a little bit more, because probably nobody knows the inner workings of this kind of rate setting process better than Joe. So a group of Mike, Dan Hamill, and Brian and I are looking forward to having a meeting with Joe and a conversation, which of course we will report back on. But this is the second item on the wish list.
Stephen, if I could, I would just add super fast to what Stephen is talking about. You know, Medicaid, when we talk about they're reimbursed, but it never really covers the true cost of a service. So anybody that's offering Medicaid reimbursable services always has costs to run an organization that will not be covered by Medicaid rates. Part of that is because the Medicaid rates may not be the same as Medicare rates. Part of it is it's just not designed that way. And so in both of these situations, we have services, and even trying to keep the services that we had and not addressing improving or adding, but to stop losing them, we really need to address these holes. And for legislators, I think it's also really important. A Rep Rule as a social worker, a clinician themselves, is far more sophisticated understanding than most. I would be willing to bet you most legislators thought, didn't we do something about that behavioral health workforce last session? So that's why it really threw us on this committee to realize sometimes they take action and it doesn't do exactly what they need it to do. So hopefully with Rep Rule's knowledge of it and also Joe Valentine, we can suggest a really good, as Stephen said, kind of end around that will be far more effective. I just want to highlight that Rep Rule's memory was solid, and she's like, we addressed this, right? Yes, and right, we did, and it didn't get down to anybody. We're still losing people, and they're going to private practice. So I just wanted to just do that brief aside, just to share that bit of learning we had. Thank you, Stephen, and on to 3.
That was helpful, Mike, and thank you for deepening that item and the reasoning behind it. The third item on the wish list came up thanks to Courtney Taylor's report that people going into the jail sometimes wait weeks before they can see a prescriber for psychotropic medications that they need or want. And part of that is because there is so little funding and such a limited pool of people with legal prescriptive authority that the jail just doesn't have the capacity to bring people in very often. It's a couple hours a month. And so, as I said, people can wait weeks before they get the medications that are appropriate. So we decided to add to the list, number 3, to increase funding for the jail or the health department, I guess, to be able to expand the capacity under contract, both in the amount of hours that we could purchase, but more or just as relevant, Right now, prescriptive authority is limited in the kinds of medical professionals who can actually write those prescriptions. There was a bill in past sessions. It's been reintroduced this session. It's HB 1041 that authorizes clinical psychologists with certain training to also prescribe psychotropic medications, excuse me. And so we are looking to expand the legal prescriptive authority and expand the funding that would allow our jail and our health department to contract for more hours on behalf of the detainees in the jail. I'm going to loop back to this because Brian has substantially rewritten this and I haven't read that yet. So Brian, you can explain that when I finish the last one. And the last item was for us, and again, an attempt to sort of localize and end run around a non-functioning state system that has been a barrier to competency evaluation, competency restoration. Most of you are aware that a number of years ago, there was a settlement in a class action lawsuit against DSHS and Western State Hospital called the True Blood Settlement that was supposed to expedite competency restoration, competency evaluation down at Western State Hospital in Thurston County. And there has been a little bit of progress. There is a tiered plan over multiple years where Whatcom County is on the waiting list several years down the road still. And DSHS simply has not been complying with the pace of the settlement terms. They pay tens of thousands of dollars a year in court sanctions for that non-compliance, and they seem not all that motivated to change the pattern of those services, which is not to say there's not any effort going on, but it's far from adequate and it's far from what the court required. So, you know, we here in this locality and most others around the state face a backlog from this lack of compliance with the True Blood settlement. And so we wanted to, Representative Rule and Senator Shoemake, to explore the ability to create something locally that would be an alternative to this. Some of that might require some legal authority for that. Certainly some of it would require additional funding. Many of you have seen circulated a DSHS memo, and we have further elaboration from Dr. Thomas Kinlan, who heads the True Blood settlement with DSHS, outlining the package of services, which are really quite substantial for the competency restoration program for the 11 counties that are currently the first tier of implementation for the True Blood settlement. This is one of those things that turned out to be much more complex than we anticipated. So I think Brian has done some revisions there. But those are the four things: operational funding, secure operational funding for the Crisis Stabilization Center, expanding legal authority and funding for prescriptions for in-jail detainees, the additional targeted service reimbursement rate for direct service behavioral health providers in the community, and a localization option for competency restoration services. Brian, why don't you take it away from there and add to what I summarized?
Thanks, Stephen. Well, in terms of option 3, you can see what was originally what we originally came up with, and I just updated it basically to acknowledge the current bill 1041 on the prescriptive authority of psychologists. And there is pushback by some medical providers on this. They've already had their first hearing on this. And then also the second part about targeted additional funding. I mean, Perry Mowry did come up with some estimates of what the cost might be to have a psychiatric nurse hired, full-time with prescriptive authority, or hiring a full-time psychiatrist. I mean, there's a number of options for how you could increase the availability of those types of providers. I guess my question is how would the state provide this? Is this a budget proviso we're asking for? I'm just not quite sure when we are planning to meet, by the way, with all three of the 42nd LD reps in the next couple weeks and discuss this, in a little bit more detail with them. But so that's really all I did. I mean, I did change the number one to just acknowledge that we endorsed the firehouse model. And I don't know if many of you have seen this letter from the Pioneer Human Services, but I actually attached it to this as a add-on. And so we can forward this to the whole committee. This is a letter from Pioneer Human Services. This is their legislative ask related to this firehouse model for crisis stabilization. And I might add that Inslee's proposed budget does have, related to behavioral health, does have a line item on crisis stabilization services. So there's already a place where this funding could be acknowledged on an ongoing basis. So that's all I have to say here. I just want to also mention, Michael mentioned earlier, I don't know if we're going to have time to do it today, but we have a data specific ask to Whatcom County and possibly the Public Defender's Office to get a little bit more information on timely psychiatric prescriptions in the jail and the number of people that are in jail awaiting some type of competency restoration service. I think as we go forward with this, it would be helpful to have those some data on that, and I can share later if we have time just a couple of data asks related to that from the jail and possibly from the Public Defender's Office. So I'll stop there in terms of our legislative ask.
So I'll just flesh this out a little bit more, Mike, if I could jump in here. There are a couple other aspects of this. Our idea was to really put our finger on problems and hope that the expertise of the legislators could figure out how best to address those. We're getting a little more into the weeds in kind of shaping what we think the solution might be than our original intention, but it appears that that's necessary for us to be persuasive on these. A lot of them have to do with bring up their own implementation issues. For instance, when we talked about increasing the availability of a prescriber serving jail detainees, Jackie Mitchell talked to Chief Jones in the jail, and she said, well, you can have all the prescriptive provider coming in you want, but I don't have a ready answer to where that would take place, or I don't have the staff to escort them and supervise them for that. So there are some practical side issues on implementing some of these things, and there are a number of others. County Council member Buchanan, as most of you know, has convened a sort of internal to county government discussion group on competency restoration issues. We debriefed Councilmember Buchanan on the fourth item, and the outcome of that was that Mike and Brian and I will attend at least one, maybe ongoing, that work group meeting to talk about the intersection of our wish list with their discussions. Perry has been an intimate part of those as well, so it'll be a good blending of this committee and that county employee work group. And the last thing is, one of the things that both Representative Rule and Senator Shoemake asked us was, to seek out and confirm an alignment of these items that are on our wish list with the larger legislative agendas that the county and the city of Bellingham already have through their own lobbying staffing. And so we've spoken with City Council member Hamel and Mark Gardner, the legislative assistant for the Bellingham City Council. We're trying to arrange communications with Executive Sadoo's office about the county legislative agenda. Council member Buchanan is heading that. And so there are some other efforts on that alignment issue as well going on. And Mike, I'll turn it back to you, and I'm not sure where you want to take this beyond this.
Well, I think it's a really good summary, and hopefully that wasn't overkill for the rest of the committee members that weren't necessarily a part of all that. And I suppose at this point, you know, what I would do is invite in, right? So you from the larger context you're hearing, we're in a legislative season. It is in session, I'm sorry, and it's a longer one, which is good news, but fortune favors the quick. So that's why some of us have been meeting outside of these meetings to continue to move this football, if you like football analogies, I do. We're trying to move this further down the field, and we needed to do it with greater frequency than the committee meets. That being said, this came out of this committee. The priorities came out of this committee. And it actually stemmed from a meeting in this committee. So I want to, you know, one, thank the committee and its participation. And two, I think I would also do some invitation. So I know we've got some members of law enforcement, we've got behavioral health treatment providers. So when you look at this wish list, and when you think about it, you know, if you have knowledge of something, or if you have a particular issue that you would want addressed this year, did you find this missing? Would you advocate something in additional? And obviously, just encouraging, even and beyond the scope of the task force, just to mention that our legislative district representatives and newly elected senator, they have some decent esteem and ear for what we're doing. And I think they understand the nature of this group, the problem-solving nature of this group, and that we're innovative and we want to stay that way. So with that, I guess I want to just invite in if there are any particular issues from task force, from committee task force members, something that was glaringly missing. If you liked what you saw in there, you know, we've got a couple of minutes, and I would just invite that, because it really is supposed to be of and from, you know, kind of all of us. So with that, Under Sheriff Chadwick, I saw you come back on camera, and I wondered if that was maybe you had something to add in at this time.
No, I agree with the priorities. Certainly, when it comes to competency evaluations, trying to get people the appointments in a timely manner, creates other issues, and obviously our limited staff. And I think everybody knows that the space constraints we have, it also creates a lot of safety issues for not just the people that are in jail, but also our staff as well. So certainly, Brian asked about the number of people that are waiting for competency hearings. I should be able to pull that together. And would it be beneficial to get I can get average bed days probably along with those stats. I can get that from Chief Jones. That shouldn't be too difficult. And again, the other thing is certainly support, additional medical staff to come in here and get people the medications, get them stabilized while they're here. But as Stephen mentioned, and Chief Jones alluded to, we just don't have the space. Our medical unit up there is quite confined already. So to add additional services in the current facility is problematic. So that's just my input on those.
Yeah. Under Sheriff Chadwick, if I might just add, I think the specific ask I was thinking about was to what extent are there, detainees that need a competency or are not competent to stand trial related to the True Blood timelines of 14 days and 7 days. And I can send that. I'm sure you're familiar with that. For all of 2022. how many detainees that needed restoration were in the jail for how long, and I assume they probably did not meet those 14-day and 7-day timelines. I apologize, Michael and Stephen, we haven't really discussed this, but does that seem like a reasonable day to ask?
Yes.
Okay.
One of the things, and this is just for the benefit of all, that the legislators asked is for specificity, and they want to know impact. And obviously this helps them know, how big is this issue that your constituents and your law enforcement in your area and your criminal legal system is facing. So it helps to kind of add punch to that. I would argue from a human rights standpoint, one person waiting an extra day is a problem enough. But as we know, there is power in numbers, and it's good to know the scope of the issue. And I think as you hear from Under Sheriff Chadwick, it's part of the reason competency question came off for legislative ask. We need to do some homework, and we need to figure out, what does that collaboration look like with the jail? What would that entail? It might include additional staff to escort, to have the person evaluated and seen by a provider at another location. So, thus it's not so simple, right? And we're going to need to work group that. So I intend to attend as much as I can that internal work group that's going to continue to noodle on that. Under Sheriff Chadwick, please, I see your hand up.
Just follow up. Is anybody aware of discussions about a regional facility in Snohomish County for competency? I know obviously, we need something other than Western State, especially up here in the Northwest quadrant.
Courtney, I don't know if your hand up is responding to that. I'll go ahead and call on you, or.
I was just going to chime in and say I've heard, but it's very loose right now, and I doubt. I'm hopeful, but I doubt it's going to happen, honestly, just because the phasing of the True Blood settlement and the restoration locations has flexed a lot from what they originally planned on. Yeah.
That
go
will
ahead.
be, I'm sorry, Mike. That will be one of the things we can talk to Joe Valentine about with the ASO. And the other thing I should add, and I don't think I did for some reason, is we have followed up with Dr. Kinlan from DSHS, the manager of the True Blood settlement, and arranged for him to join us for the March joint meeting that this subcommittee has with the Legal and Justice System subcommittee to talk about what's going on. He thinks he's going to explain what's going on with the True Blood settlement. The part 2 of that will be us telling him what we think needs to go on, or what alternatives we have room to come up with in that. So we've arranged what we hope to be a very informative and constructive conversation for that March joint meeting.
Courtney, is that a new hand up from you?
Yeah, just wanted to say again, just another kind of lens reminder. Anytime we're talking about restoration and competency issues, just speaking broadly here, I just want to remind us all that the way we talk about, and this isn't just a local thing, I think it's a national thing. When we talk about criminal justice, the criminal legal system, we often, the first 2 entities we think of as law enforcement and prosecution, they're absolutely part of the picture. Absolutely cannot, we have to all be at the table. That said, I want us to remember that a huge piece of this is the voice of the defense and our clients and their attorneys. And the True Blood settlement, I mean, that came out of Disability Rights Washington. That is also shaped with a defense perspective. So just wanted to add that again, because we're talking about a lot of big things that, like Mike said, are complicated.
Courtney, excellent point. And you're bringing that lens to that work group that created these priorities. And I think as we go together in creating solutions is key. And by the way, we got some feedback that we're kind of noted for being able to sit it down across the table with our various hats, right? Like I come from a housing provider perspective. We have law enforcement, we have jail, we have defense, we have prosecution, really all trying to work to make at least some situational improvements till we get a new facility. And that is one of the things, and yeah, I went ahead and said it, I think we're going to get a new facility, we need one. But we also know that there's going to be situational improvements we need to make between now and then. We can't pin all the hopes on reform or transformation or better treatment for prisoners or better work conditions for our law enforcement unless it just can't sit for 5, 6, 7 years till we have a facility. So I want to thank everybody for rolling up sleeves and working at this, and Courtney for your bringing up your points. It's an extremely important lens and really brings the human side. With that, I want to pause for just a second and see if my co-chair has anything else. We are nearing close to the end of the agenda, and I just want to check in real quick.
Mike, sorry, but can I have a couple
please.
minutes? Can I have a couple minutes at the very end, because we want to talk about some another data request related to delays in prescribing psychiatric drugs too.
You know what, Brian, that is actually pertinent to the existing agenda item. If you would please go ahead now, actually. That would
Okay,
be
I'm
wonderful.
gonna try and share another document. Hold on here. Just give me a second. Okay. So we already talked about this first. Can everybody see that?
Yep, we can see it, Brian.
Okay, so and this was and I'm not sure I have this right, but walking in terms of the competency evaluations within 14 days and competency restoration services within 7 days. So how many detainees lacking competency to stand trial failed to meet this criteria, and how long did it take for them to receive these services? That's what I'm proposing. I mean, I'm open to suggestions or changes, but I just came up with that. I just latched on to 1 full year. And I was just curious, Courtney, does your office have any data on these types of issues?
We do, but because of the nature of our work, I don't know that I can speak to specifics on that right now. That would have to be something that would go to my supervisor, because our stuff on our end is pretty confidential.
Well, Under Sheriff Chadwick, does this make sense to you?
It does. I will, I'll converse with Chief Jones and see what we can do to provide that.
Thank you. And real quick here, I included some other, this is the state's True Blood like website or webpage.
Brian, can I interject here for just a second?
Yeah.
I want to loop back to Courtney. Courtney, we're not asking for anything that would be identifying any individual or any particular circumstances. We're asking for aggregate or unidentifiable data, and I'd be disappointed if your office couldn't provide that.
No, we absolutely do have data. Yes, we do. I just can't provide that right now.
Absolutely, absolutely.
Yeah, no, we're just talking about the number of detainees, not. So I just wanted to really quickly here, in this True Blood, they do here, they have state data on this. And then also, where is it here? In terms of True Blood implementation, here's down here in yellow, you see it where it says Salish region. But I think, as Courtney mentioned, this is aspirational. I believe the implementation, including, Whatcom and the Northwest counties, is delayed. And then here, these are the counties. These are the 11 counties that Michael was alluding to earlier. So to continue with our second request, so this is what I'm proposing. down at the bottom, our data request is from the jail and possibly public defender's office. How many detained individuals failed to receive a timely assessment and appropriate psychiatric medication in 2022? For such individuals, how long did it take to receive treatment? And I recognize this is kind of general, but we're just trying to, as Mike and Stephen mentioned, kind of wrap our minds around. So what's the extent of the problem? How many individuals does this affect, and how long has it taken for them to receive appropriate medication? And then I have some material from this DSHS best practices for behavioral services in jail settings, the criteria why it's important for people to have, timely assessment and medication. So, and again, I'm just proposing this. If people would like to change this or think we need to take a different approach, I'm open to that. I just wanted to get the ball rolling here with these 2 data requests. And the reason it's timely is we can go back to our state legislators and say, look, this is the extent of the problem here in Whatcom County. I think it's really important to frame the argument with a little bit more specificity than we have perhaps in the past.
Right, I would just add that makes sense. It's kind of what our legislators pushed us to do, and that's when we started banging the drum. We realized you're going to need to get this. So that's very appropriate. Obviously, this is the first time I'm seeing this now. These seem to make sense, and I think the key thing is we're hearing from Undersheriff Chadwick that it makes sense, and also from Courtney, who's can't necessarily speak for the public defender's office, but it sounds reasonable, rational, and will help us come to a better solution. Any other comments on what Brian has introduced? It sounds like, Brian, that your requests are well met. I think they will fuel future meetings. And I would just add to the committee, if we didn't already very clearly, we will be following up with our legislators. So I would just invite, if there were things, Undersheriff Chadwick spoke and mentioned that these are in alignment in good legislative priorities to be advancing. If you have other ones, obviously you are free as your own. If you have some that you did want to bring up, please reach out to your co-chairs or reach out to any member of the steering committee. Like I said, we're still in the middle of session, and while we don't intend to add much to those meetings, we never want to close the door on that, right? And we want to make sure that it's really open. I mean, these ideas really came from the committee, and we want to keep reporting back and then solicit additional. With that, unless there's anything else, I would close this agenda item and then go back to Councilmember Hamel if there was anything to add, and any thoughts, Councilmember Hamel, you had on future agenda topics. I know we want to come back and hit number 1 again. We'll obviously have an update on priorities. So with that, I'll turn it over to Councilmember Hamel briefly.
Yeah, thanks. No, this is great. This is, I think we're all on the same page in terms of the data requests. And yeah, I think that all my points have been hit, so I don't really have much to add. I think one thing, Mike Parker, you had talked earlier about housing, and that keeps coming up at intersections in our discussions. So I would like to get a handle. I'd like this committee to understand how the Lighthouse Mission's efforts to open a larger facility in Old Town, how that's happening, and what that timeline looks like, and the services that would be offered. I would submit that could be a future agenda item. I'd also like to get the Bellingham Police Department's take on camp cleanups, pardon me, and what's happening with that as an item related to Parker, to your discussion on housing and homelessness. I think that just keeps coming up over and over again. So I want to get a handle on those 2 items, and that's all I really have to add at this point.
Along with that, Whatcom County has another advisory committee on housing. And I'm not sure who the chair of that particular group is. I used to attend those meetings. It'd be interesting to hear what they might have to say on the way I term it, and this is just unofficial, it's just dedicated housing to people who've been in our criminal legal system. I after many years of being in this industry, I still think we've got room to grow in this area. And for people who have served their time, we want to be doing a better job as a community, targeting housing to those individuals. They face a steep road based on just their life circumstance and what they've done. I'm sorry, what they were maybe incarcerated for. But, you know, if we don't target those resources, we're not going to move the needle in that. So I might add in, whether it's next meeting or a future one, a report from the Housing Advisory Committee on, you know, how are you addressing as a committee that specified need, right, for a population who may be involved with our criminal legal system. Brian?
I just wanted to say to Under Sheriff Chadwick and Courtney, I'll email you that document that I just shared with the language on the data requests. And please feel free to get in touch with me if you need some more information or clarification on what we're asking for. Thank you.
Thanks, Brian. I'll forward that to my supervisor. That's going to be who that document needs to go to. So I'll make sure she gets it. Thank you.
And Brian Thane, I see you. I see your hand up, and I think I may have spoken about a committee that you're on.
Yes, and once again, I am chair of the County Housing Advisory Committee. They have not broached that topic. So the next meeting is in February. I'm going to miss that meeting, however. But I suggest we reach out to Chris D'Onofrio. Chris is primary staff for that committee.
Okay, great. We'll do that. And thank you for that, Brian. And I think I knew that in one level, but kind of forgot on the other level that we had a chair sitting with us here. So, you know, Brian's group at the Housing Authority has administered a very large shelter plus care housing grant that could, you know, possibly be part of the answer. Brian, really quick, back to you.
Yeah, Michael and Stephen, would you have a moment to just stay on to talk about the legislative ask document?
Sure.
Because we are meeting with Joe Timmons on Friday.
Jill, can we keep this open after we close the meeting?
Yes.
With you? Wonderful. With that, Jill, I think we're getting close to wrapping up. We've got some items for the next agenda. In the interest of time, we are slightly over. I don't see any good of the order from us. Is there anybody for public comment, Jill?
Yes, we have 2 attendees right now. If either of you would like to speak to the committee, please virtually raise your hand. No hands are raised, and I don't see any attendees in our council conference room.
Right. With that, we will go ahead and adjourn January's meeting of the Behavioral Health Subcommittee. Thank you for all of your input, your time, and energies as we kick off this new year. Look forward to seeing you all at the next upcoming meetings.